In 2019, a woman in her late 60s went to her doctor feeling completely well. No symptoms, no complaints. She was active, sharp, and by every subjective measure, healthy. Her doctor suggested a full-body scan, preventive, comprehensive, peace of mind. She agreed. The scan found a 3-millimeter nodule in her right lung. The report recommended follow-up imaging in 3 months. 18 months, 4 scans, 1 specialist referral, and a biopsy later, performed under general anesthesia with a 2-day hospital stay, and a subsequent lung infection that required a further course of antibiotics. The conclusion was confirmed. The nodule was benign. It had almost certainly been there for decades. It would never have caused her any harm. She told her daughter afterward that those 18 months were the worst of her life. Not because of the procedures, because of what happened between them. The waiting, the imagining, the certainty growing in the back of her mind that something inside her was quietly killing her. Nothing was killing her. The scan found a shadow that medicine then could not simply leave alone. This is what researchers call the Cascade effect, and it begins with a single test, often a test ordered when the patient felt perfectly fine. Today, at the Eternal Vigor Way, I am a health researcher. I have spent months reviewing the published evidence on 4 specific medical tests that the research consistently shows cause more measurable harm than benefit in adults over 60. I am going to explain what each test does to the body and to the mind, and what the evidence actually recommends instead. This is not an argument against medical care. It is an argument for understanding what you are agreeing to before you say yes. Stay through all 4, because the 4th one is the most counterintuitive and affects the most people. Before the 4 tests, one concept needs to be understood clearly, because it is the common thread running through every harm documented in this video. The cascade effect works like this. A screening test is performed on a person with no symptoms. The test finds something, a nodule, a shadow, a number slightly outside the reference range. That finding may be completely harmless. It may have been present for years and will remain present for decades more without causing any problem. But medicine, once it finds something, cannot easily leave it alone. The liability exposure of not following up is greater than the risk of the follow-up itself. So a specialist is ordered. The specialist orders a more detailed test. That test produces another ambiguous finding. A biopsy or procedure is recommended. Each step in this chain carries independent risk: infection, bleeding, anesthesia complications, procedural injury. Each step also carries psychological cost: weeks or months of anxiety, disrupted sleep, altered behavior, reduced physical activity, driven by fear. At the end of the cascade, the majority of findings turn out to be incidental, the medical term for things discovered by accident that would never have required treatment. The patient is not healthier for having found them. In many documented cases, they are measurably worse. The research on this is not preliminary. It is robust, replicated, and published in leading medical journals. The problem is that the evidence rarely reaches the person sitting in the examination room when the test is being offered. Commercial whole-body MRI and CT scans are marketed directly to consumers with language centered on control, prevention, and comprehensive knowledge. The premise is straightforward: scan everything, find problems before they become dangerous, intervene early. When researchers scan healthy adults over 60 with no symptoms, they find incidental abnormalities in approximately 86 to 90% of participants. Small pulmonary nodules, renal cysts. These findings are not rare. They are the normal internal landscape of a body that has been functioning for 6 or 7 decades. Radiologists describe them in clinical language that sounds alarming because the language of radiology is designed for sick patients, not for healthy ones. A prospective study following adults who received whole-body scans found no mortality benefit compared to those who did not receive them. The scanned group did not live longer. They did not detect meaningful disease earlier. What they did experience was a significantly higher rate of follow-up procedures, specialist referrals, and documented anxiety and depression. The scans did not make them healthier. They made them sicker, not from disease, but from the medical response to findings that would never have harmed them. The alternative is not ignorance, it is functional assessment. Can the person walk up 2 flights of stairs without becoming short of breath? Can they rise from a chair without using their arms? How is their balance? These functional measures correlate far more strongly with health outcomes in older adults than any imaging finding. A physician who spends 30 minutes conducting a functional assessment will identify more actionable health risks than a scan that produces a 30-page report full of incidentalomas. Age-associated memory changes are not pathological. Walking into a room and temporarily forgetting why, taking a moment longer to retrieve a name. These are documented normal features of cognitive aging that occur across the entire population of healthy adults over 65. When anxiety, often the anxiety of adult children rather than the older adult themselves, drives a brain MRI to investigate normal forgetfulness, the results are predictable and consistently problematic. Brain MRI reports in adults over 70 routinely include findings described as mild cerebral atrophy. These terms describe the appearance of every aging brain. They are not diagnoses. They are radiological descriptions of what brain tissue looks like at 75, the same way a dermatologist would describe age spots on skin. However, delivered to a patient in clinical language, they produce a specific outcome. Patients develop elevated anxiety about dementia and reduced engagement in social activities. The imaging had not identified disease, but the language of the report had created the behavioral signature of someone who believed they had it. Research scanning cognitively healthy adults over 75 found that over 90% had MRI findings classified as abnormal by standard radiological criteria. Over 90%, the image does not reflect cognitive function, it reflects age. The appropriate clinical response is an office-based cognitive assessment, validated tools that take 10 to 15 minutes and directly measure memory and processing speed. When these tests identify a deficit, the next step is not imaging. It is a systematic review of reversible causes, medication side effects, vitamin B12 deficiency, thyroid dysfunction, depression, sleep apnea, or hearing loss, each of which is documented to produce memory symptoms that fully resolve with treatment. Imaging is indicated when the pattern of decline is progressive and rapid, or when geographic disorientation in familiar environments appears. Before the final 2 tests, which include the one that most people find most surprising, I want to stop here. What you have just heard is not a fringe position. It is documented in the peer-reviewed literature of radiology, neurology, and geriatric medicine. This information exists. It is accessible. And yet most adults over 60 are never given it before they consent to a test. That gap between what the research shows and what reaches the examination room is exactly what the Eternal Vigor Way is built to close. Every week, this channel translates clinical evidence into honest, practical information. Subscribe right now before we continue, because the next 2 tests involve risks most people are never warned about. Subscribe, then keep watching. Cardiac stress testing, typically a treadmill electrocardiogram, is a valuable diagnostic tool in the right clinical context. The right context is a patient who has symptoms: chest discomfort with exertion, unexplained shortness of breath, palpitations, near syncope. In that context, a stress test provides meaningful diagnostic information. Chest discomfort with exertion, unexplained shortness of breath, palpitations, near syncope. In that context, a stress test provides meaningful diagnostic information. The wrong context is ordering a stress test on an asymptomatic older adult primarily because they have reached a certain age, or because a protocol requires cardiac clearance. Here is the clinical problem. Stress tests have a documented high false positive rate in older adults. Physiological changes associated with aging, reduced maximal heart rate response, baseline electrocardiogram changes from decades of normal cardiac aging, the effects of antihypertensive and rate-controlling medications, produce abnormal appearing results in people with no significant coronary disease. The test says something is wrong when nothing is wrong. This false positive then initiates the cascade. The patient is referred for cardiac catheterization, an invasive procedure where a catheter is threaded through an artery. Catheterization carries real procedural risks, including arterial injury, contrast-induced kidney damage, cardiac arrhythmia, and stroke. When the catheterization is performed in response to a false positive stress test, it frequently reveals the expected findings of an aging heart, some degree of atherosclerosis, perhaps mild narrowing, but nothing requiring intervention. When performed in response to a false positive, it frequently reveals the expected findings of an aging heart, some atherosclerosis, but nothing requiring intervention. The patient emerges labeled as a cardiac patient. New medications are added. Physical activity is restricted out of caution. The psychological consequence, a diminished sense of physical capability, reluctance to exert, withdrawal from activities that were previously safe and beneficial, is frequently irreversible. For asymptomatic adults who want meaningful information, the evidence supports a coronary artery calcium score. This is a brief, low-radiation CT scan requiring no exertion. It quantifies calcified atherosclerotic plaque in the coronary arteries and produces a numerical score that stratifies 10-year cardiovascular risk with significantly greater precision than a stress test in an asymptomatic individual. A score of 0 indicates very low near-term risk. An elevated score identifies someone who benefits from aggressive preventive intervention, lifestyle modification, statin therapy, aspirin consideration, before a cardiac event occurs. The calcium score informs prevention. The treadmill stress test, ordered inappropriately, primarily initiates procedures. If you can walk at a comfortable pace, climb 2 flights of stairs, and carry out your normal daily activities without chest discomfort or unusual shortness of breath, your body is already conducting your stress test every day. It is passing. This is the test most people find most difficult to hear because colonoscopy's reputation as a life-saving cancer prevention tool is well-deserved and accurate within the appropriate age range. Colonoscopy prevents colorectal cancer by identifying and removing precancerous polyps. For adults between 45 and the early 70s, colonoscopy at appropriate intervals saves lives. This is not in dispute. The question is whether that benefit to risk calculation remains favorable beyond age 75 in individuals with no prior polyps and no family history. The evidence reflected in guidelines from the United States Preventive Services Task Force and the American Gastroenterological Association answers that question with increasing caution. The risk side of the calculation changes with age in ways that are clinically significant. The bowel preparation required before colonoscopy, the high-volume electrolyte solution consumed the evening before, carries documented risk of dehydration, electrolyte disturbance, and acute kidney injury in older adults, particularly those on diuretics or with baseline renal impairment. The sedation used during the procedure carries higher risk of respiratory depression and post-procedure confusion in older adults. The risk that concerns gastroenterologists most is perforation, a tear in the colon wall caused by the colonoscope. The colon wall thins with age. The risk that concerns gastroenterologists most is perforation, a tear in the colon wall caused by the colonoscope. The colon wall thins with age. Published data documents that perforation risk approximately doubles between age 65 and 80 and increases further beyond 80. Colonic perforation is a surgical emergency requiring immediate laparotomy. In an older adult, emergency abdominal surgery carries significant morbidity and mortality. The outcome, in some cases, includes a permanent colostomy. In an older adult, emergency abdominal surgery carries significant morbidity. The outcome, in some cases, includes a permanent colostomy. The benefit side of the calculation also diminishes. Colorectal cancer that develops from a polyp takes 5 to 10 years to reach a clinically significant stage. An adult who is 80 years old and in reasonable health may not live long enough to benefit from the early detection of a cancer that would take a decade to cause harm, while facing the procedural risks immediately. For adults past 75 with average risk, the appropriate shift is from invasive screening to symptom surveillance. For adults past 75 with average risk and normal prior examinations, the appropriate shift is from invasive screening to symptom surveillance and dietary prevention. The symptoms that indicate colonoscopy, regardless of age, are blood in the stool, persistent unexplained change in bowel habits, unexplained abdominal pain, unexplained iron deficiency anemia, or unintentional weight loss. These symptoms require investigation at any age. For prevention without procedural risk, the evidence supporting dietary fiber is substantial. Regular consumption of legumes, cruciferous vegetables, whole grains, and fruit feeds colonic microbiota that produce short-chain fatty acids, particularly butyrate, which directly inhibit colonic epithelial inflammation and reduce polyp formation risk. This is not a substitute for appropriate screening in the right age range. It is the primary preventive strategy for adults for whom the risk-benefit calculation of further invasive screening no longer favors the procedure. These produce short-chain fatty acids, particularly butyrate, which directly inhibit inflammation and reduce polyp formation risk. This is the primary preventive strategy for this age group. The 4 tests described in this video share a common structure. Each is genuinely valuable in the appropriate clinical context. Each becomes potentially harmful when applied without individualization. The 4 tests described in this video share a common structure. Each is genuinely valuable in the appropriate clinical context: symptomatic patients, high-risk individuals, the right age range. Each becomes potentially harmful when applied without individualization, when protocol replaces judgment, when age alone or administrative habit drives the recommendation rather than a careful assessment of that specific person's risk and likely benefit. The cascade effect is not a theoretical concern. It is documented. Increased anxiety, depression, unnecessary procedures, and critically, no improvement in survival outcomes. The question every older adult has the right to ask before any diagnostic test is not simply, could this find something? The relevant questions are, what happens if it does find something? What is the probability that finding would ever cause me harm if we left it alone? What are the risks of the investigation and treatment that would follow? And given my age, my overall health, and what matters to me, is that benefit to risk ratio in my favor? What is the probability that finding would ever cause me harm if we left it alone? What are the risks of the investigation and treatment that would follow? and given my age, my overall health, and what matters to me, is that benefit to risk ratio in my favor? These are not unreasonable questions. They are the questions that informed consent requires, and asking them is the exercise of medical intelligence. If this video gave you something you can bring to your next medical appointment, then you already understand what the Eternal Vigor Way is here for. Every week, this channel goes through the clinical literature on aging and translates it into honest, practical information that gives adults the tools to participate in their own health decisions. No alarm, no agenda, evidence explained clearly. Subscribe before you close this video, because next week we are covering the 5 medications most likely to be doing more harm than good in adults over 70. This is the Eternal Vigor Way. The most important question in medicine after 60 is not always, what should we look for? Sometimes it is, what happens after we find it?